competition. And I will leave now the floor for Dr. Ashraf Al-Amir to start our scientific meeting for today. Dr. Ashraf, the floor is yours.
Okay, can you see my screen?
It started to be sharing. So you cannot see the slides yet. Yes, now we can see them.
Okay. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, السلام عليكم ورحمة الله وبركاته and جمعتكم مباركة بإذن الله. أدعو الله سبحانه وتعالى أن يجعل هذا اللقاء لقاء مثمر ويعم بالنفع على الجميع بإذن الله. So today my topic is very unique, where we are going together, closing the gap and identifying the importance of adherence and fixed dose combinations therapy in the patient with diabetes management. So, but before I start, let me just pave the way and set up the stage by saying a very important concern of all of us. After managing patients for many years with diabetes, still we did not achieve the target goal. And in spite of having a smart molecules, we have a wonderful guidelines, and we have also understood the pathophysiology of diabetes. Still, we are lagging behind to secure the best control of diabetes, not only globally, but with a special focus in our area in the Kingdom of Saudi Arabia, where we have a high prevalence of patients with diabetes. So today in my presentations, I'm going to touch upon 5 different pillars, or I can say the domains, in fact, because it's a huge items. So we are going to highlight why type 2 diabetes was not controlled and why patients failed to reach this glycemic control, what are the factors making them fail to secure the control of diabetes using the monotherapy or the dual therapy, and what are the reasons. And then we'll move towards a very important part, which is demonstrated by majority of us as clinicians, which is the therapeutic inertia. Why treatment intensification is delayed, and what is the burden of this delay on the patient's life, quality of life, and even the burden on the healthcare system. And then we'll move to the medications non-adherence, what is the prevalence, and what are the causes, and what are the economical burdens on our healthcare system. And then we will identify the fixed dose combination therapy, and we'll identify also the adherence inertia. And finally, we will land up in the most important part of our presentation is the triple fixed dose, where we are going to combine the 3 different molecules, which is empagliflozin, linagliptin, and metformin to secure this interest. So before I start, let's understand exactly why diabetes type 2 is not controlled using monotherapy and dual therapy, and how far the patients are far away from glycemic control. All of us, we know that diabetes is a global health emergency globally, with a special focus in the Kingdom of Saudi Arabia. So it has been identified that about 42.8% of patients with diabetes achieve the recommended A1C. So it's almost 50% control their diabetes, and the others, they are not well controlled. And as we have learned from the IDF many times, that we are going to witness a doubling in the number of our populations of diabetes by the year of 2050. So the year 2050 is a very crucial year, where we're going to anticipate tsunami of diabetes if we don't allocate the proper resources to manage our patients with diabetes. Not only this, but also 60% of patients with diabetes, they are at high risk of getting into the cardiovascular mortality and morbidity. And as we know, we have learned that about 8 out of 10 patients with diabetes, they die because of the cardiovascular consequences. So despite of the availability of effective pharmacological therapy and non-pharmacological therapy, glycemic control remain the suboptimal. And when we look into the monotherapy efficacy, which declines over time, and it has been proved by many compelling evidence and a lot of trials. So the efficiency decreases over time, and it become ineffective in the management of glycemic control. So that's why we have to think about what else we can do by adding more medications to have the dual therapy and even the triple therapy. So the early treatment with combination therapy has been the name of the game to make sure that we control the glycemic control in patients with diabetes. And as we are going to go through different presentations and slides, the recommendation of the guidelines has been recommended aggressively the use of the combined therapy in a stepwise as we go. So let's start by type 2 diabetes in adults management in 2026, the NICE guideline. So as you can see, the NICE guideline has recommended the approach to type 2 diabetes, which has been tailored according to the patient comorbidities rather than relying on the hemoglobin A1C. And this is a very important point. So long time ago, our target was just to achieve the A1C, but nowadays we have a broad mind of management that we look into the profile of patients and identify what are the comorbidities, like those patients with obesity, with chronic kidney disease, with established cardiovascular disease, heart failure, and even frailties. So the guidelines recommend considering to start with two agents rather than one agent, and this is metformin can be used as the monotherapy, and then the additions of other medication to be on top of the metformin. And why these guidelines has recommended the use of the combined therapy, because definitely there is certain beneficial outcome. One is we are going to achieve a better A1C reductions, which will ultimately improve the quality of life and delay the treatment failure, which is most of the time we encountered as a physicians. Not only this, but also we are looking, nowadays we speak a different language of terminology in the management of patients with diabetes, which is a cardiorenal metabolic benefits. So we are not to treat the A1C or to achieve the target A1C, but also to add on top of it the preventions and even the benefits. And also, we might reduce the complications of diabetes by having this type of combinations therapy. Of course, we know that diabetes is a progressive disease, but it doesn't matter how much we do. Again, the patients will be ultimately landing in the complication. But what we do is just to delay the complications. So it's very obvious in the NICE guideline that the metformin and SGLT2, as you can see, was the preferred first-line dual therapy in most of the patients when it comes to identifying different comorbidities like cardiovascular, chronic kidney disease, heart failure, and early onset of diabetes. So these are the profile of patients where we should start the dual therapy. SGLT2 inhibitors become, as you see, the fundamental therapy along with metformins to improve the cardiovascular and the renal outcome. So let's go to other guideline, which is this is the recommendations of the dual therapy. Another guideline is the ACE, the American Association of Clinical Endocrinology, which has also stated a very elegant statement how to go in a very specific algorithm to manage our patient with diabetes. So we start by the lifestyle modifications and lifestyle interventions, which is the foundations for the management of patients, all patients with type 2 diabetes. And then we go for the treatment selected according to the comorbidities. So we are focusing on the comorbidities again, rather than the A1C. So this is very important here to identify that if the hemoglobin A1C is more than 9% or 1.5% above the target, so we start the dual therapy immediately. So this is one of the landmark recommendations that tell us how to be aggressive to tackle this kind of uncontrolled diabetes. So the preferred therapy, as you can see here, for patients with heart failure, and chronic kidney disease, SGLT2 inhibitors is the recommended medications. And for atherosclerotic cardiovascular disease or high cardiovascular risk, we use the GLP-1 and SGLT2 inhibitors. Those with stroke or transient ischemic attack, we might use the GLP-1 and so forth. So this is the glycemic target should be individualized. So now we are living in an era of one size is not fit for all. So that's why we have to customize our management plan based on the patient profile. So using the biopsychosocial model and the different profiling of patients that we can encounter. So this is again the ACE 2026. So again the lifestyle. So this is the glucose-centric algorithm. The previous one was the comorbidities algorithm. So if the patients, again, we start by the lifestyle modifications and metformin. So the first, we have to assess the comorbidities like heart failure, chronic kidney disease, atherosclerotic cardiovascular disease, and TIAs. And if it is not present, so there is no major comorbidity, so we choose therapy that based on the patient priority. So we have to consider here the severity of the severe hyperglycemia, the risk of hypoglycemia, the obesity, and the cost is also considered. So again, the same statement was repeated again here, which is the hemoglobin A1C, if it's more than 9% or 1.5% above the target, so we can start the dual therapy. And if the patient comes with hemoglobin A1C more than 10% or glucose more than 300 milligram per deciliter, so definitely this patient has to be a patient with to be treated with insulin therapy. So let's go again to the other guidelines, which is well respected, which is the American Diabetic Associations. So here again, we can find the same common start with lifestyle modifications and diabetes. So and diabetes self-management and education. So this is how we start, and then the treatment should be prioritized based on the kind of renal protections. So we might use the GLP-1 receptors, or we might use the SGLT2 inhibitors in patients with atherosclerotic heart disease, or if indicators of high cardiovascular risk, or patient with with heart failure, or patient with a chronic kidney disease, as you can see in the left side of the slide. But again, you can initiate combination therapy in patients with A1C more than 1.5 to 2% above the individual target. So we can use the dual combination therapy. So the only difference is between 1.5, now it is 1.5 to 2% above the individual target, so we can start the combination therapy. So additional therapy should be selected based on weight loss, efficacy, glucose lowering potency, hypoglycemia risk, and others. So it's very important here that we have to have the regular assessment of patients every 3 to 6 months. So, sorry. Yeah. So why glycemic controls usually failed, and what is the impact of non-adherence? Usually, medications adherence is a major determinant of hemoglobin A1C. And the less patients adherence to treatment, the higher their hemoglobin A1C. And this is a very common scenarios. So every 1 point increase in non-adherence associated with 0.16 to 0.21% increase in the hemoglobin A1C. So this is a fact. And the patients with a good adherence, they achieve 1.14% reductions in the hemoglobin A1C compared with 0.75% in non-adherent patients. So this will highlight that the poor compliance will secure the uncontrol of diabetes, and the good adherence will improve the control of hemoglobin A1C. And we can remember from the landmark study, which is the UKPDS, that 1% reduction in the A1C associated with 37% reductions of the microvascular complications. So this is a very rewarding outcome that we have to work on, and that's why patients' adherence on the medications is the ultimate goal. So there is usually, as you can see here in the graph, about 0.4% difference between hemoglobin A1C reduction is due to adherence itself. So this is the gain that we are gaining of adherence. So the poor adherence is usually associated with not only the poor control of diabetes, but also associated with the higher diastolic blood pressures and high LDL. Why? Because we know majority of our patients with diabetes, they are not presented with diabetes alone. They are presented with a metabolic syndrome. So that's why the poor compliance on blood sugar control also will result in a consequence of poor control of hypertension and hyperlipidemia. So the bottom line here, which I would like to say, the best diabetes medications is only effective if the patient take it. If the patient doesn't take the medication, the management will fail totally. So improve that adherence definitely will improve the glycemic control and will reduce not only the cardiovascular complication, but all the different complications of diabetes across the board. So why glycemic control fails? Treatment complicity and the polypharmacy is a major component of this failure. We know that people with type 2 diabetes usually develop chronic conditions, hypertension, diabetes, dyslipidemia, osteoarthritis, depressions. So that's why these people, unfortunately, they have this polypharmacy. Unfortunately, with this polypharmacy, we're treating multiple comorbidities and the treatment become more complex. So that's why the patients might get frustrated and the patients will be not accepting these huge quantities of medication. So the medication adherence decline as the number of daily pills increase, and this is a fact. So the poor adherence also lead to the suboptimal, of course, glucose control and the worsening of the long-term outcome. So what I would like to mention here in this, now we'll move towards another part, which is the therapeutic inertia. Why treatment intensification is delayed, and even when patients need is the most. So this is the clinical inertia, which we also call as the therapeutic inertia. And they have many definitions for the therapeutic inertia, but the one which I like it the most is the failure of the physician to start or to up-titrate or to combine or to perform certain intervention for the patient who need this kind of intervention, and it is declared clearly recommended by the clinical guideline, and the physician failed to do it. So this is how the therapeutic inertia or a clinical inertia is defined. So clinical inertia can be demonstrated in every single step during the management of patients with diabetes. So during the first part, in the lifestyle modifications, where we use the diet and exercise, so majority of patients, they stay for a long period of time trying this kind of lifestyle modification before we start the medication for many months or even 4 years. Even in the first line management, when we use a single medications or dual medication or triple medications or addition to insulin, also in all these systems, there is multiple areas of delay. So why it's matter? It matters because it's prolonged the exposure to the hyperglycemia, and we know the hyperglycemia is a devastating outcome because of the glucose toxicity and inflammation. Not only this, but also clinical inertia worldwide, according to different 25 systematic studies review, involved more than 575,000 patients. So it shows that 50% of the study report clinical inertia, more than 50% of type 2 diabetes. And the highest was in USA. So even the high sophisticated healthcare system in the world, in the United States, even different countries, still the clinical inertia is of a concern. So it's a time now to intensify the therapy. So actually, we should not wait at all. So the clinical inertia delay the treatment intensification when the patient needs it immediately to counteract the high blood sugar and to preserve the control of patients. So this is the problem. So in the real world practice, it has been shown that the median time to add another oral agent is more than 7 years. So this is very huge delay, and this is a delay that exposes patient to the complications. Not only this, but also even if the hemoglobin A1C is between 8 to 9.9, intensification is delayed by 17 months, more than 1.5 years. So even if the blood sugar or the hemoglobin A1C is more than 10%, the delay is about 10 months. So the guidelines usually recommend reassessing and intensifying therapy every 3 months. So just keep it as a rule of thumb that 3 months is the period which is recommended by all the guidelines to reassess the patients for intensification. So the bottom line that I would like to mention here is that the timely treatment intensification is essential, and any delay in escalations will prolong hyperglycemia and predispose the patient for the adverse consequences of diabetes complications. So let's see. In the real world evidence, the clinical inertia is present. And this is very interesting study, which has been highlighted in the Cleveland Clinic study, which involved more than 7,000 patients with hemoglobin more than 7%. So they were already receiving 2 oral anti-diabetic medications, and they found that the treatment intensification was frequently delayed. So even in those countries with a high sophisticated system, there is clinical inertia and therapeutic lagging behind the proper intensification right at time. So time factor is very important. So nearly 2/3, it's about 60%, 63% had no treatment intensification with 6 months despite the uncontrolled diabetes. And even among patients with A1C between 8 to 8.9, only 53% were not intensified. And so 44% of the patients with hemoglobin A1C more than 9% still did not receive the treatment escalation. So this is a pure delay in the management of patients with diabetes. So the clinical inertia, again, remain very common in patients with hyperglycemia, and early and timely intensification is essential to improve the glycemic control and to reduce the risk of the long-term complication of diabetes. So what is the root cause of the clinical inertia? Root cause of clinical inertia, usually we used to say it's because the failure of the treatment is because of patients. And we blame patients most of the time. But according to this study, it showed that patients contributing only 30% of the clinical inertia. And the failure of the treatment is majorly contributed by physicians. So the providers, the healthcare providers, doctors, nurses, and even healthcare providers, they contribute for 50%. And most of the time we say because we have only just 15 minutes consultation time, so limited time, and we cannot cope up with the different guidelines that is upcoming. And we have some of the doctors, they don't have adequate knowledge, and they have concern about the safety of the medications like hypoglycemia. That's why this could be an excuse for them to delay the complication and to keep the patients on minor therapies that will not be enough to control diabetes. But again, when we look into the patient factors, majority of our patients, because of the nature of the disease of diabetes, is a chronic disease. So the patient lives with it for a long time and maybe lifelong. So the fear of the side effect, this is one of patients, they misunderstand the treatment. And we know about during our consultation, patients just retain 30% of what we say about what we tell them. So they don't retain much. So misunderstanding or unretention of the information is an issue. So multiple comorbidities is most of the patients they have, and they have a lot of issues that they have to focus on, not only diabetes, and the poor health literacy. This is another factor for adherence. So that's why our role is to convert our patient from inert, inactive, into active, proactive, interactive patients. So these patients will be can sit with us in a common shared understanding, and they will identify their role on compliance on medications. But again, there is another factor, which is the healthcare system factor, where the healthcare system, majority of the medications are costly, cannot be afforded, and even there is no clinical guideline in the healthcare system that govern the practice of primary care and secondary care within the clinical guidelines. And then the approval of the insurance companies they constitute part of the healthcare system contribution to the failure of the treatment because of the approval. So the better medications adherence is associated with higher likelihood of timely treatment intensification, addressing the provider, patient, and system type. So once we'd like to manage this failure, we have to put solutions to tackle the factors that is related to patient, doctors, as well as the healthcare system. So what are the most common fears and concern of patients with type 2 diabetes? These patients who are poorly, patients with diabetes, they live their life long in suffering from diabetes and its complications, and they have certain concern. What will happen for them in the future? What different type of complication of diabetes they will be landed in? Are they going to have heart attack or amputated lower extremities, or they will get blind, or they will have renal failure and they have to have a renal transplant because of the failure? So this is the fear. And they have identified in this study that the risk of the severe complications was the greatest concern in most of the patients. And many patients usually worry about the lifestyle which has been so restricted. Most of the time we ask the patient not to eat and to be compliant with the certain restricted dietary habits and lifestyle modifications. So this is another concern. But as you can see in the graph, there is another common concern, like the side effect of the medication. It happens many of the time when I diagnose patient with diabetes, the patient will say, how about the medications? I'm afraid of starting the medication because of the side effects. I tell him that the complication of the disease is much more worse than the side effect of the medication. And that's why our role as a physicians, we should balance between the risks and benefits of to treat or not to treat the patients. But definitely we have to treat. So the side effects of diabetic medications, and the need for insulin injection, the tympanophobia, which is very common in this part of the world. Patients are reluctant to start injection, and it's a nightmare for us as a physician when we make a decision to start insulin. So patients will reject, and we will have no choice but to reinforce the concept of the importance of using insulin. Medication costs, especially the new modalities of treatment, like the GLP and GIP-1 medications, which is very expensive, and not most of it are covered by the insurance. And the weight management is also another contribution. So the medications non-adherence, this is the third part of the domain of my presentation. We're going to highlight the prevalence, the root cause, and the clinical and economical complications of not taking the medication as it is described. So here, the non-adherence of medication is the norm, but it is not an exception. So this slide shows that the poor medications adherence is a common in type 2 diabetes, like any other chronic disease, but it's more worse in patients with diabetes. About 38 to 45% of patients, they don't take their medications as prescribed. So this is a fact. So that's why every single encounter with patients, we have to make sure that we ask about the compliance of the medications. So the adherence in oral glucose lowering drugs is unfortunately only about 60 to 68%, which is about 30% they are not adherent. Adherence to insulin gets more worse. It's about only 40 to 64%. And for the GLP-1 and GIP injections, the adherence is only about 43 to 54%. And in some studies, the adherence oral therapy might fall up to 50% in the first year. So non-adherence is a major contributor for a failure of the glycemic control. So what we have to do, we have to simplify the treatment and improve the patient education, which is essential to improve the long-term outcome. So why patients don't take their medications? Of course, we have to understand the behavior and the psychology of our patient with diabetes. Majority of them, they forget to take the medications. And this is the very common reason. And it's patients come to us, he said, Doctor, I forget to take the medications because I had a busy lifestyle. I have, unfortunately, have multiple medications, and I'm taking more than 10 medications every day for 10 different conditions. And I don't have somebody to remind me, and so forth. So this is why the patient forgets, and that's why we have to think about the solution. The solution for this, we might have once daily regime, okay, or we have fixed dose combination could be a very good solutions, to counteract this forgetfulness. So the patient might have multiple medications combined together for hypertension, as we see nowadays, for diabetes, and even for dyslipidemia. So the pill organizer, this could be another solutions, and a smartphone reminder. So that's adding technology into our practice. So the second reason why the patient don't take their medication is a fear of the side effect. So they skip the dose because they have certain side effects. For example, nausea, vomiting, they have the weight gain, and they witness some kind of complications based on their individual variability between patients. And the most important thing in my point of view is the regime complicity. Those patients, they're having multiple tablets, different dosing, and they have multiple instructions to take different medications. So this will make the regime very sophisticated and very complex for the patient to understand. So that's why the simplifications of the treatment of having this combined fixed doses will solve the problem. So patients, they might have some kind of dissatisfactions of the use of the medications. If the tablet is big and the patients have a large tablet, or it has an unpleasant tasting, or it is inconvenient, so this might contribute to non-adherence. So there is a regional difference in Saudi Arabia. In Tabuk study confirmed that these findings show the forgetfulness. Patient forget was the leading cause of the missing medication dose. And so the medication adherence is not only about the drug, it is about the patient experience. So we have to focus on the patient experience to make sure that the patient accept the management plan and accept the modality of the treatment. So fewer doses, better adherence. So this slide will show that one daily release metformins achieve better adherence than the release of than immediate release formulation. So that's why we use the XR, the sustained release, which will cover the patient for 24 hours rather than using multiple doses. And the more frequently medications are taken, the greater the risk of non-adherence. The Saudi Society of Endocrine and Metabolism recommended the fixed dose combinations to contain 2 drugs or maybe more for the management of patients with diabetes. So this is non-adherence drives complications and mortalities. And this is very important to have this kind of association. If the patient is non-adherent, so this will be a very strong driver for hospitalizations and for hospitalization and health cost on which will shoulder the healthcare system with a lot of consequences. So here it shows that the patient who adherent to glucose lowering therapy, they have 31% lower risk of hospitalization or emerging or emergency department visit. But there is a meta-analysis which shows also the good adherence reduced the risk of hospitalization by 10%, which is quite rewarding. And in contrast, non-adherence patients will have 41% higher inpatient healthcare cost increment. So the point here, which I would like to emphasize upon, so improving medications adherence benefit both the patient and the healthcare system by reducing hospitalizations, by reducing the cost, and improving the quality of life of patients. So how to break the cycle of poor diabetes control. So first of all, we have to focus on the treatment complicity. So multiple pills and polypharmacy definitely will reduce the adherence. And the poor adherence, of course, this would result in inadequate glycemic control, and therapeutic inertia also can contribute to the failure of the treatment. And this will lead to a poor outcome and enhance the complications and hospitalization. And this negative outcome further reduce the patient satisfactions, and ultimately the patients will be out of control. So the fourth part, which is another part which is very important, so I will go with it as fast as possible. The fixed dose combinations, which is the major part of our presentation. So beyond adherence, fixed dose combinations improve the clinical outcome. So this slide will show that fixed dose combinations will provide the hemoglobin A1C reductions when they are taken in comparison to the separate tablets. So the benefit is about minus 0.53% additional reductions. And patients who are receiving fixed dose combinations, they usually experience fewer cardiovascular events, as you can see here, 105 versus 139 events per 1,000 person. So this will improve that the fixed combination will reduce the cardiovascular complication. Not only this, but also the fixed dose combination reduce the risk of heart failure by 12%. And in adults who are age more than 65 elderly populations, they have 21% lower risk of the heart failure. So this are the benefits of fixed dose combination to improve the overall conditions. So meditations analysis showed about 47% of reductions in heart failure risk, as explained by improving medications adherence. So now we'll go to the importance of using the triple therapy. Triple therapy in the form of metformin, DPP4, and SGLT2 inhibitors. And this has been highlighted in a Chinese expert panel, version 2025. So I'm sorry for this busy slide, but the recommendations of this was the initial triple therapy if the hemoglobin A1C remain above the target after 3 months of dual therapy. So if you have patients on the dual therapy for more than 3 months and the A1C is not achieved, so it's a time to use or to initiate the triple therapy. What are the other recommendations? Newly diagnosed patient with hemoglobin A1C more than 9% or 1.5 above the target, initial therapy, triple therapy may be considered. So this is another indication when to use the triple therapy. So who are the patients who are eligible to have the triple therapy? As you can see here, those who cannot tolerate high dose of metformin, or those who are in need to have simplifications and maintaining the efficacy of the medication which is combined together. So the fixed dose combinations are recommended whenever it is possible because of the simplicity and improve adherence and enhance the long-term glycemic control. So this is another study for people with type 2 diabetes and high cardiovascular risk, and SGLT2 and GLP-1 based therapy with demonstrate cardiovascular benefit is recommended independent of the hemoglobin hemoglobin A1C or metformin, and this was being recommended by the American Heart Association, by the American College of Cardiology, the American Diabetic Association, and the European Society of Cardiology in 2026 up to 2023. So stepping up from dual therapy to triple therapy is one of the modalities where we can improve our outcome to our patients. So this is a study which showed empagliflozin added to linagliptin and metformin, and this study was conducted on 24 weeks randomized double-blind placebo-controlled trials. And here the patients with hemoglobin A1C between 8 and 10.5 on stable dose metformin first receive linagliptin 5 milligrams for 16 weeks. And then those still in hemoglobin A1C between 7 to 10.5% were randomized to receive empagliflozin 10 milligrams and empagliflozin 25 milligrams and placebo, so 3 arms. So the intervention was conducted for 24 weeks. It was a double, and the main objective of adding empagliflozin to metformin plus linagliptin to provide additional glycemic benefits compared with continuing with metformins plus linagliptin. So this is how the study results showed. So the study showed the hemoglobin A1C reductions was significant greater in empagliflozin with placebo. So it was estimated about with empagliflozin 10 about minus 0.65%, and for empagliflozin 25 was 0.56%, and the placebo was as low as 0.14%, which is and more patients achieved the glycemic control, as you can see here on the right side of the slide. 37% with empagliflozin 10 milligrams, 32.7% with empagliflozin 25, and 17% with placebo. So the bottom line here that adding empagliflozin to metformin and linagliptin significantly improved the glycemic control. And as you can see with the figures that we have discussed, is almost nearly doubling the proportions of the patient achieving hemoglobin A1C less than 7%. And this will support the effectiveness of the triple therapy. So this is the slide will show the safety profile. And so the safety profile of comparing the placebo and empagliflozin 10 milligrams and empagliflozin 25 milligrams when it's added to metformin and linagliptin. So these groups are well balanced. As you can see, the mean age the same, the hemoglobin A1C was the same, and the safety outcome was overall were lower with empagliflozin than placebo. And there was serious side effects were uncommon, in fact, as you can see, and no death and no hypoglycemia, which was quite rare. But again, the study also showed the adverse event when combining the linagliptin, empagliflozin, and metformin. So there was no additional side effect which was recorded. So the study, sorry. Right. Okay. So this is empagliflozin as added on therapy with patients with type 2 diabetes inadequately controlled with linagliptin. And as you can see here, this is, we have discussed it. Okay. Sorry, I don't know what happened. Okay, right. All right. So I would like just to conclude my presentation. I don't know what happened to my presentation. So just to conclude by saying there is a fewer than half of patients with type 2 diabetes reach the hemoglobin A1C target, and we have seen even in the Kingdom of Saudi Arabia, the target achieved A1C by patient with diabetes doesn't exceed more than 37%, but again, 50% of type 2 diabetes patients, they reach only the hemoglobin A1C. And as we have seen in the different studies and the compelling evidence that monotherapy loses its efficacy over the time, non-adherence is about up to 44% of patients. they don't take their medications as prescribed, and this will drive the complication and increase the hospitalization and increase the host. And we talk also about the clinical inertia, which is exerted by many physicians across the board, and it shows that about the delay is almost 7 years before the treatment intensifications, and this will highlight the importance of starting the medications right on time and follow the patients on 3-month basis to assess the conditions and to make sure that the patients receive the appropriate treatment. And the fixed combined doses closes, in fact, the gap, and will improve the adherence by 29%, and this will improve the hemoglobin A1C and will secure the cardiovascular, renal, metabolic benefits to the patients and reduce. This will also include the heart failure reductions and improve the patient's adherence. So the bottom line, I would like to say that it's not all about working hard, it's about working better. So we have a challenge that diabetes in a rise. We demonstrated failure in management of patients with a traditional methodology of treatment. So we have to intensify the patients based on the recommendations of the different guidelines. And we have to understand the patient behavior and to establish a good doctor-patient relationship to improve the adherence and ultimately the ultimate goal of using fixed dose combinations using metformins, linagliptin, and SGLT2 inhibitors. In these combinations will secure the best interest of our patient to reach a target goal and to delay the complications of diabetes. With this, I would like to thank you for being listening to me, and I hope I get some 10 minutes to answer your questions. So thank you so much.
Thank you so much, Dr. Ashraf, for this insightful presentation and for raising awareness about that gap in the management of type 2 diabetic patients. I'm reminding all of our attendees to drop their questions to our speakers, Dr. Ashraf and Dr. Raed, in the Q&A section. We received till now a couple of questions. The very first question is asking about if type 2 diabetes due to insulin resistance, what is the benefit of insulin injection?
Okay, we know that insulin injections like the GLP and GIP will reduce the insulin resistance by reducing the weight and reducing the body mass fats, the body fat mass. And not only this, but also still, if we can go to the oral medications like metformins, metformin also can reduce the insulin resistant. And we know that the name of the game in the development of diabetes is the insulin resistant, because there will be hyperinsulinemia because of the insulin resistant, and then the pre-diabetes will take place, and then diabetes will be as a full-blown picture. So managing the diabetes by GLP and GIP will reduce the insulin resistant as well as the other medications, in fact, like metformins and others.
Okay, the second question is asking if a patient is uncontrollable by combined linagliptin and empagliflozin together with insulin, how will be the management? Noted that there is no comorbidities with proper adherence to treatment and lifestyle.
Okay, so lifestyle is the first step that we have to ensure in our management, and then we have to intensify the treatment. If the patient has hemoglobin A1C more than 9% or 1.5 to 2% above the target, we have to initiate the dual therapy and even the triple therapy according to the different recommendation. This dual therapy could be metformin, DPP4, SGLT2, could be GLP-1, GIP. So this kind of choice can be made based on the patient profile. And we said first, before we look into achievement of the A1C, we have to look into the comorbidity profile of the patient. So that the patient has established atherosclerotic cardiovascular disease, the choice of the combination will be SGLT2 as well as a GLP-1. If it's a chronic kidney disease, it will be the same SGLT2. If the patient is obese, we have to think about the GLP-1 and GIP. in combination with metformins and others, of course. So, and if the patient is on insulin with this kind of combinations, and we would like to we would like to add on top of it other medications, we have to make sure that we have to adjust the dose by reducing the dose of insulin by 5 to 10% or 20% in order not to push the patient for hypoglycemia.
Okay, another question asking about why linagliptin over sitagliptin.
Well, linagliptin is one of the DPP-4 which has been shown to be excreted not in the kidney, and that's why we can use it in patients with chronic kidney disease or renal impairment without the need of adjusting the dose, unlike the sitagliptin and vildagliptin. But again, linagliptin is just not only for patients with renal impairment, but we can use it as a DPP-4 molecules that have the beneficial effect to reduce hemoglobin A1C between 0.6 even to 1%, and it's a weight neutral. So we don't have the fear of increasing the weight, and it doesn't causes hypoglycemia as well. So there are certain features for the DPP-4 in general, and with the special features of being beneficial to patients with renal impairment using the linagliptin.
Okay. Another question asking, is there any explanation for the smaller number of those who benefited from empagliflozin 25 compared to empagliflozin 10 milligrams? I think he's asking about the numbers in the trial.
Yeah, the trials, yeah, I understand this was one of the observation, but it was numerical variations. But later on, the 25 was more superior to the 10 milligrams in other studies as well. So it's a numerical variability.
Okay. What about some patients who ask all the time for aspirin and also vitamin B supplements in diabetic patients?
Of course, aspirin cannot be used unless it is, for secondary prevention. And the vitamin B12, we should not use it for granted. We have to, even for those patients with diabetic peripheral neuropathy, we have to prove that there is a vitamin B deficiency, and then we can treat. And of course, those patients who are on metformin for more than 5 years, 4 years, 5 years, definitely metformin will impair the absorptions of vitamin B12. But again, we have to prove that there is a vitamin B12 deficiency, then we can use the supplement of vitamin B12. So the bottom line here, there is no recommendation, there is no clinical guide recommendations to use the vitamin B12 for granted for every patient with diabetes, unless proven that he has this kind of deficiency.
Okay. Another question about the trials as well. Was the improvement seen in randomized trials or only observational studies? The shared trials were randomized, I think.
Yeah, I absolutely, yeah. It was a randomized controlled trials, yes, observations. Yeah, I agree. Yes.
What is the most important factor in preventing diabetic complications besides lowering A1C?
See, lowering the A1C is the main goal to lower the complications, and it has been shown by the UKPDS that lowering 1% of the A1C will be accompanied by 37% of reductions of the microvascular complication, even heart failure and macrovascular complication. But again, to prevent the complications, proper follow-up and early identifications of these complications early stage, on top of the tight glycemic control, will make will keep us in a position to identify this complication and treat in early stage. Definitely having this kind of doctor-patient relationship and making the patients aware and educated to adapt healthy lifestyles and to reinforce the lifestyle modification, non-pharmacological treatment along with the pharmacological treatment. This will enhance the overall control of diabetes. But again, according to the different trials, it shows that patients usually tend to go into complications, but our role is to delay this kind of complication and to give the patient the opportunity to lead a life which has a quality life, even with these kind of complications.
Okay, another question asking about your advice for primary health care, where it is not possible to identify all the comorbidities at the commencement of therapy, and specialist review could be delayed for months. They are asking about your valuable advice.
Again السؤال معلش ما فهمته.
They are asking about the advice for primary health care professionals, asking about how to identify the comorbidities at the commencement of the therapy, because the specialist review is delayed, the therapeutic inertia.
Yeah, of course. So when the patient with diabetes comes for the first time, of course, we have to, as a primary care physician, we have to look into the patient in total, and we have to assist the patient full assessment, diabetes and what other comorbidities he has. He has hypertension, dyslipidemia, or he has some other risk factors that promote him to have a disease in the future. So within the first encounter with patient, we'll put these kind of lists, and then we put the priority, which one should come first based on the evaluation of the risk of that particular condition. If it's diabetes, I will treat diabetes. I have to treat the hypertension, dyslipidemia, to prevent the cardiovascular complications on the long term. So even non-identifications of these different comorbidities could be considered as a therapeutic inertia. So a therapeutic inertia is not only limited to the intensification of the medication or adding combined fixed doses, but also identifying the different elements of the patient that might have as a comorbidities, and then treating the comorbidities. Of course, as a family physicians and a primary care physician, we treat majority of these conditions, but again, we have to refer the patient from time to time in timely manner to the subspecialty. And this could be another therapeutic inertia if we don't refer patients to ophthalmologist to check his eye, to cardiologist to make sure, to the nephrologist, to the pediatrist for the protective sensation of the feet and so forth. So we have to look into the patient with diabetes in a very comprehensive way, addressing diabetes and addressing the different comorbidities right on time.
Sure. Last two questions for the sake of time. The very first one is, if a patient is pre-diabetic and lifestyle modification failed, could we use metformin alone?
Yes, of course. Pre-diabetes has been identified to be a full-blown picture and a disease by itself, because many trials show that even in pre-diabetes, there is a microvascular and macrovascular complication, and even there is a cardiovascular mortality and morbidity has been recorded. So the first modality of treatment of pre-diabetes, lifestyle modification and metformin, and then acarbose and TZDs, and then GLP-1 as recommended by different guidelines. So we have to be even aggressive in management patient with pre-diabetes between 5.6 and 6.4 percent of hemoglobin A1C.
Okay, last question. How to modify treatment based on the eGFR, estimated GFR? Treatment modification based on the kidney function, the GFR.
Okay, the eGFR, of course. There is different recommendations to use, for example, metformins and even SGLT2 based on the eGFR. If it's below 35%, it shouldn't be used. If it's above, between 35 and above, we have to adjust the dose. So there is recommendations based on the eGFR and the patient who have a chronic kidney disease using the metformins and the SGLT2. So based on these recommendations, we have to tailor the dose or based on the kidney profile of patients.
Thank you so much, Dr. Ashraf. Thanks to our attendees for your questions. It's time now to leave the floor for Dr. Raed Al-Dahj for the second session about the key updates that took place in 2026 from guidelines and international congresses. Dr. Raed, the floor is yours. We can see your screen now. Great.
Hello, the voice is clear?
Now, yes, yes.
Yeah. The screen is clear?
Yes, we are seeing the third slide. Yeah.
Okay, good, great. So, first of all, good evening, good afternoon for all of you. And special thank and Jum'ah Mubarakah for all of you. Special thank for Dr. Ashraf. He make my life is easy, and he just give an introductions for my talk. Special thank for Eva Pharma. Always they are supporting HCB education, HCB. HCB education, supporting always the awareness for the physician. Special thank for my colleague they are attending in this weekend and Friday to attend to listen to my talk. We have more than almost 900 people. They are attending today and try to see and we discuss with them our topic today. So thank for all, and we will start our talk about very important disease actually, which is, as you know, it's growing worldwide. We have a lot of problems in diabetes. The incidences try to be increased everywhere. In our country here, in our region, we have this problem. Today, we will go through the guidelines. We try to see what's the numbers of diabetes worldwide, what we have in our country. Then after that, we will go a little bit we will talk about which kind of medication we can use, what the advantage of some medication in other medications. Then we will take you in this journey. Then after that, we'll take your question if you have any at the end of this talk. So today we'll go through these agendas. We go to the global diabetes landscape in 2026. Then after that, we will talk about ACE guidelines, the American College of Endocrinology in 2026. What's the algorithm update? Then we'll go for the guidelines coverage, ADA, NICE guidelines, the British and American College of Endocrinology, then ADA, AST, the European Society of Diabetes. Then we'll go for NICE guidelines, what's their update. Then we'll go for ADA standard of care, American Diabetes Association. Then we'll talk about ADA, ASD, draft consensus highlights. Then we'll go for next generation obesity therapy. Then we will take home message and we'll discuss with you at the end all of these things. So we will talk to you about the global diabetes landscape, and I will try to focus on some numbers as available in my country here. So global diabetes burden in Saudi Arabia, we have more than 21% Saudi adult type 2 diabetes prevalence, which is one of the highest in the world. So we have a lot of type 2 diabetes in our country. The problem is when we tried to look for those numbers, we found that more than 50% of them, they are uncontrolled, their hemoglobin A1C 7 or more, which is one of the major problem that we face it in our country. We have more than 5 million people with type 2 diabetes in Saudi Arabia. And the problem is this is very growing every day and every year. Annually, we have 3 to 5% annual increasement. We have 60% plus, they are in 2 agent or more, and they are still not controlled. Now, if we go for the current treatment pathway, we see that we start with lifestyle modification. Then we go with metformin. Then after that, we choose SGLT2 inhibitors. It's one of the well-known medication to be chosen, plus minus DDP4 inhibitor. Some of the patients, when they refuse injectable medication, we go for sulfonylurea. Then after that, we try to talk to them about injectable therapy like GLP-1 or insulin. So type 2 diabetes account for more than 90% of all diabetes cases globally. Cardiovascular diseases is one of the leading cause of death in those patients with type 2 diabetes. So that's why when I give any talk, I ask the audience why we treating diabetes. Usually we treating diabetes to prevent the complication. And one of these complications is cardiovascular complication. Obesity is one of the strongest modification risk factor for type 2 diabetes, and usually it's progressing. So we start with the obesity, then after that, insulin resistant, then type 2 diabetes came after. Now we'll talk to you and show you the guidelines what said in the last updated one. So in January 2026, in ADA, American Diabetes Association, they said the standard of care is SGLT2 inhibitors and / GLP-1 agonist is cardiovascular and renal protection. And we should look for other parameter like systolic blood pressure should be less than 120 millimercury for high-risk people. CGMs, they talk to us, we expand the use for those patients with type 2 diabetes, especially in basal insulins. And also they try to talk about new heart failure algorithm, which medication can support for those patients with heart failure. Then in the NICE guidelines, in the update in February 2026, they give us very big move, actually. They said SGLT2 inhibitors start to be moved as a first-line therapy for most of the type 2 diabetes. And they try to move in what we call a triple therapy, so metformin, SGLT2 inhibitor, and semaglutide for atherosclerosis cardiovascular diseases. And this is one of the medication that it will be protection for cardiovascular disease. Then in March 2026, the ACE guidelines, American College of Endocrinology, they're going to be more aggressively, and they said new diabetes classification sections. They try to talk about lifestyle modification, and they try to focus as obesity treatment is primary pillar for those patients. Then in the last June, just last month, 2026, ADA-ASD consensus, they said earlier GLP-1 agonist SGLT2 inhibitors from diagnosis is one of the holistic care expansion to muscle, or what we call it fatty liver before, cognitive dysfunction, osteoarthritis. So now we talk about the medication that can be protect for other complication of obesity and diabetes, and they try to be focused on fatty liver more, and they try to focus on the advantage of those patients they lost weight. So now if we try to focus on the NICE guidelines in February, so in UK, they try to have big shifts in the prescribing medication in last decade. So they try to be focused more in choosing in the first line therapy. As you know, before, the first line therapy was metformin for decades. Nowadays, they try to move from this era to talk about which kind of medication that it will help our patient more than metformin alone. So, for example, when they talk about obesity, they try to focus on GLP-1 agonist, GLP-GIP, and also SGLT2 inhibitors. And they think those medication, it will decrease weight, it will help the patient to be controlled diabetes, and it will having cardiorenal protection. So multiple advantage if you use this kind of medication. So they try to move from the first liner therapy to make the GLP-1 and SGLT2 inhibitors more be in the guidelines and more focus actually with our patient. If we talk about chronic kidney disease, for example, they try to show us, they said AGFR, if it's above 30, you can use extended release metformin and SGLT2 inhibitors. Also, GLP-1 agonist can be used also if GFR more than 20. Also, DDP4 inhibitor can be used, but not all of them. So we could decrease the dose in some of those medication. We should be cautious and contraindicated in some of those patients when their deterioration, their kidney problems, in some of the medication like sulfonylurea and some kind of DDP4 inhibitors, maybe linagliptin. It's not renal adjustment medication, but others, they have that. Early onset type 2 diabetes before age of 40. Also, they be tried, if they are overweight or obese, they try to recommend to use for them GLP-1 agonists or SGLT2 inhibitors in addition to metformin. And this will give us, the patient, more advantage to control their weight and to control their blood sugar. Heart failure with any ejection fraction, either preserved ejection fraction or reduced ejection fraction, or they call it nowadays half PIF and half REF. So those patients, SGLT2 inhibitors is one of the medication. It will decrease hospitalization for heart failure, and it will be benefit for those patients. Frailty, they offering SGLT2 inhibitors in those patients in addition to metformin, and they said this kind of medication is very safe for those patients and considered to be used for them. Also, atherosclerosis cardiovascular disease, they use for them SGLT2 inhibitors and GLP-1 agonists. Also, there is a lot of changes in these guidelines. So they said first line shift, metformin plus SGLT2 inhibitors is now first line therapy in all type 2 diabetes, regardless of their comorbidities. So metformin, it's preferred for tolerabilities. XR may be less risk side effect from regular metformin. SGLT2 inhibitors continue to be cardiorenal benefit and can protect for cardiac and renal, regardless of the glycemic control. Blood pressure, generally, we should make it less than 130/80, but now they be more specifically, they said you should make systolic blood pressure less than 120 systolic for high cardiovascular and kidney risk. So they are relaxed a little bit for elderly patient. They said we can accept less than 140. Triple therapy for atherosclerosis cardiovascular disease, they try to talk about metformin plus SGLT2 inhibitor plus semaglutide as a first-line therapy for those patients establishing cardiovascular disease or at risk of atherosclerosis cardiovascular disease. So also in the guidelines, they try to be focused that don't use GLP-1 agonists with DDP4 inhibitors. They have the same medications, and it will not benefit for this patient to give them both. Sick days rules, they provide that to stop these kind of medication, try to assess, for example, patient go for dehydrations, stop SGLT2 inhibitors, and try to resume it after the patient improve from their sickness. So in the NICE guidelines, they make it very step. So in step 1, they said if the patient don't have atherosclerosis cardiovascular disease, start with metformin plus SGLT2 inhibitors. If not controlled, start to add GLP-1 agonist or tirzepatide, or a DDP4 inhibitor or sulfonylurea. Third step, you should consider insulin or combination therapies for those patients. So it's very clear now, those patients establishing atherosclerosis cardiovascular disease, triple therapy is a first-line therapy, metformin, SGLT2 inhibitors, subcutaneous semaglutide. It will provide cardiorenal protections, and it will reduce the event for secondary preventions. In section 4, we will talk about ADA in 2026, the standard of care. We will try to focus more what's the ADA sets in cardiorenal, and also they have a section and they talk about hypertension and technology use, which is one of the major pillar to be talking about in diabetes management nowadays. So if we talk about diabetes management, we should talk about technology use. So technology use is one of the major things to help us for detection, monitoring for those patients with diabetes. So in ADA guidelines, they said in good healthy people, hemoglobin A1C less than 6.5 is perfect. So for those patients, most adult, hemoglobin A1C less than 7 is a goal. CGM's time range should be more than 70. And also time below range, which is less than 70 milligrams, should be less than 4%. Time below range, less than 54, less than 1%. Time above range, which is talking about 180, should be less than 25%. Time above range, more than 250, should be less than 5%. For those elder adult, we accept that hemoglobin A1C less than 7.5. For those people elderly with more complication, intermediate health, we can accept till 8. So time in range, we can accept it more than 50%. Time below range, less than 70, less than 1%. Time below range less than 54, less than 1%. Time above range more than 180, we should less than 50%. Time above range more than 250 should be less than 10%. Older adult with very complex poor health, any adult with limited life expectancies. So those patients usually we don't depend on hemoglobin A1C, but we should make sure that they have less hypoglycemia. So we should make sure that try to avoid hypoglycemia and a hyperglycemia as much as we can. So there is many things we should be more strength with them to reach the goal. Shorter duration of diabetes, lower hemoglobin, lower hypoglycemia risk, low treatment risk burden, pharmacological treatment that protect cardiorenal, and those medication to benefit in the weight management. Those patients we should be less strength with them. We can accept hemoglobin A1C less than 8, up to 8%, longer duration of diabetes, high hypoglycemia risk, high treatment risk and burdens, and pharmacological therapy with non-glycemic benefits. So those patients, we can accept more, be relaxed with them more and more. So if we try to look for the guidelines, the ADA, which is simple guidelines and very easy for to be read, they try to focus in which medication that you should use. They said if your patient atherosclerosis cardiovascular disease, use with them GLP-1 agonist or SGLT2 inhibitors, or if those patients at high risk of atherosclerosis cardiovascular disease, SGLT2 inhibitors and GLP-1 agonist is the first choice. Those patients having heart failure, SGLT2 inhibitors is one of the medication can be used, or GLP-1 agonist or GLP-GIP agonist with proven they are having systematic, have PIF and obesity. Chronic kidney disease of GFR less than 60, or those patients having albuminuria or macroalbuminuria plus CKDs, SGLT2 inhibitors is one of the medication that can be used, or GLP-1 agonist with CKD benefit. Weight management, so very high efficacy in semaglutide and tirzepatide, highly efficacy usually dulaglutide, liraglutide. Intermediate is GLP-1 agonist, neutral metformin DDP4 inhibitor. Achievement glycemic control is very high risk in those patients, dulaglutide, semaglutide, tirzepatide, and insulins, and also less GLP-1 agonist and intermediate in DDP4 inhibitors. So now they make it very clear. Combination therapy should be considered in people with hemoglobin A1C above target from 1.5 to 2%, in individual with high risk cardiovascular disease, or those patients establishing cardiovascular disease, irrespective of their hemoglobin A1C level. GLP-1 agonist and SGLT2 inhibitors as a combination therapy is drug of choice to be used for them. In ADA, also they focus more in hypertension. They said systolic blood pressure should be less in those patients having renal and cardiac risk, should be less than 120. Most of adults, they should be less than 130 to 80. We should be relaxed in target in those patients, very elderly, 140 over 90 is acceptable. So systolic blood pressure less than 120 is standard of care for those patients with high risk cardiorenal, and this is supported by many guidelines. Also, they try to say that for more adult individual, less than 130 to 80, this is control. ACE inhibitors and ARB, stronger recommendation, patient with albuminuria, and confirmed CKD, and we should titrate the doses. Initiation of SGLT2 inhibitors and frenulone, which is non-steroidal MRA, can be considered in type 2 diabetes with albuminuria more than 100 and eGFR from 30 to 60. Blood pressure should be measured and should be followed in each visit. Heart failure algorithm, all heart failure phenotype, we recommend for them, those patients with type 2 diabetes and heart failure, either half ref or half PEF, for glycemic management and prevent heart failure hospitalization. SGLT2 inhibitors is one of the recommendation to be used for those patients, irrespective of their hemoglobin A1C. Non-steroidal MRA, frenulone, is recommended medication to be used for those patients, especially if their ejection fraction more than 40s, in addition to SGLT2 inhibitors as chronic kidney disease patients. GLP-1 agonist can be used for those patients HFpEF plus obesity. So those patients, we recommend for them to be used. Symptomatic heart failure with HFpEF supported to be used the medication in some trial data. So those patients, we can use them for GLP-1 agonist or GLP-GIP. CKD plus type 2 plus heart failure, the FLOW trial confirming that semaglutide reduced heart failure related event in patients with CKD and type 2 diabetes. The new pathway added for heart failure prevention and treatment. Also in ADA, they try to focus in lipid, and they try to talk about this in addition to what we said. So in the lipid, there is clear new recommendation against adding fibrate, niacin, omega-3 to statin therapy. No additional cardiovascular benefits for those. Moderate intensity statin recommended for adult with type 2 diabetes more than 75. Inclisiran is emerging agent in evidence pipeline. So those patients, we try to talk to them that some indication like lipoprotein, if it's increased, or patient statin intolerance, we can use for them these kind of medications. Cardiorenal protection and CKD SGLT2 inhibitors can be continued, even if SGLT2 inhibitors, GFR less than 20, but not in dialysis for cardiovascular benefits. GLP-1 also with cardiovascular benefits, they are recommended even in dialysis patients to reduce cardiovascular risk. SGLT2 inhibitors plus finerenone is now an option for high-risk CKD patient, especially for those albumin-creatinine ratio more than 100. ACE and ARB is strong recommendation for albuminuria or CKD, titrated to highest tolerating doses. Now, what about technology? Technology is one of the major pillar and major things to be discussed in 2026, which can be used for all of our patients. So now they are expansion the eligibility for continuous glucose monitoring. They recommended at type 2 diabetes diagnosis for everyone in insulin, an agent causing hypoglycemia, or where the CGM aids management. So we try to use it for them in insulin and non-insulin, especially for those patients having hypoglycemia. Now there is oral GLP-1 agonist, which is one of the classes. Now they approved an FDA in April 2026. They call it orforglipron. So this medication, it's for weight management. The good thing in this medication, it's no food or water restrictions, so can be taken at any time in the days. Automated insulin deliveries is one of the things that we can be used for our patient. Omnipod 5, for example, they reduce hemoglobin A1C from 8.6 to 7.5 in basal insulin rate users. And the good thing in this device, it's not connected by pipe. So there is no pipe use. It's like remote control to fix this pump. Oncology hyperglycemia, new guidelines, metformin is a first-line therapy, induced glycemic in oncology patients. Sometimes if the patient still hyperglycemia, we can use some of the medications, especially for steroid user, because the steroid user, they have what we call it postprandial hyperglycemia problems. What about the pre-conception scares and pediatrics? This is very important group, special group that we should talk about them. GLP-1 and double GLP-GIP should be discontinued before pregnancy. Use contraceptive once you are in this agents. Washout period for semaglutide should be more than 2 months, 2 months or more. Tirzepatide, 1 month in the Canadian guidelines. Glycemic control should be achieved after discontinuation and before conceptions. Those patients having plan ahead. Patients on GLP-1 agonist planning for pregnancy, they required pre-active counseling at every visit. So this is in a pre-conception. In pediatric type 2, hemoglobin A1C should be less than 6.5 for most children and adolescents at lower hypoglycemia risk. GLP-1 SGLT2 inhibitor should be considered when metformin and insulin insufficient. Metabolic surgery now recommended for adolescents with class 2 positive obesity and uncontrolled hemoglobin A1C despite lifestyle and pharmacological treatment. Aerial escalation to advanced therapy recommended versus previous guidelines. Now the GLP-1 agonist prescription should be discussed in each visit for reproductive age. Wash period is required in advance planning. Now we will talk about the consensus in ACE guidelines, the new consensus, and what's the update there. So in ACE guidelines, which is one of the guidelines I like, usually they make very simple in diabetes control algorithm. They said lifestyle modification is one of lifestyle intervention is one of the first liner therapy in type 2 diabetes. Also, they said select based on the complication, the treatment that you have. For example, for those patients having one hemoglobin A1C more than 9, so they are 1.5 above the target range, start to use double therapy for those patients. For those patients, heart failure, SGLT inhibitors and GLP-1 agonists or GLP-GIP is one of the medication that we should use. CKD, we should use for them SGLT inhibitors, GLP-1 agonist. Atherosclerosis, cardiovascular disease, or high-risk atherosclerosis, GLP and SGLT inhibitors is the medication of the choice to be used. Stroke and TIA, GLP-1 agonist and pioglitazone is medication of choice. Muscle, GLP-1 agonist, GLP-GIP plus pioglitazone is medication of choices. Then individualize the treatment. And as you know, the goal we should reach hemoglobin A1C less than 7, especially for those patients, they don't have any complications. So regardless of use, we try to focus here in glycemic centric approach. And in other problem, we try to be more in complication centric approach. Depending on those complications, we choose the medication that we proper to be used for those medications. Also here, they try to be focused more on some cases. For example, those with severe hypoglycemia, we know that basal insulin plus prandial insulin is treatment of the choices, plus minus GLP-1 and GIP. This will make severe hypoglycemia is more. Those patients having hypoglycemia risk, there is certain medication. We know that these kind of medication will not cause the hypoglycemia, like metformin, SGLT inhibitors, GLP-1 agonist, GLP-GIP, DDB4, TZDs is one of these medications not causing hypoglycemia. So try to avoid sulfonylurea. It will increase risk of hypoglycemia. Overweight or obesity, GLP, GIP, GLP is one of the medication of the choice. It will decrease the weight. SGLT inhibitors also. Metformin, some patients, they will decrease the weight, especially PCOS. But for example, TZDs, sulfonylurea, those medication for sure, it will increase the weight. If the cost is a problem, usually we try to choose for the patient, the medication is more cheaper, like TZDs, sulfonylurea, also some of the medication, it will not be expensive, like alpha-glucanase inhibitors, but usually we try to avoid expensive medication like GLP, GIP, SGLT inhibitors, which more expensive for those patients. So if the cost an issue, we try to use the medication. It will not be cost for the patient. And we try to have what we call it personal-centric approach. So in algorithm, they try to make it very easy. They said lifestyle and obesity first. So we should discuss with the patient about lifestyle modification. And we should discuss for all those patients overweight or obese to be go for them, what we call it weight-centric approach. And also we should discuss with the patient having already comorbidities. We have a comorbidity-centric approach. If the patient having already comorbidities, we try to talk to them and giving them the pharmacological therapy to achieve and to prevent and decrease these complications. So we hit one medication, we had two things with one pole. So we tried to decrease the complication and in the same time to control diabetes. The new diabetes algorithm and classifications, they try to be beyond the glycemic control. They try to look for all risk factors. They try to avoid all hypoglycemia risk. They try to choose the medication that it will control diabetes and in the same time it will prevent hypoglycemia. Also in the guidelines and algorithm, they try not to forget the very important things, especially nowadays after we talk about communicable diseases. So the CDC, they try to say that vaccination update recommend for all diabetic patients that to take pneumococcal vaccine more than 19 years, RSV more than 60s. So for adult with type 2 diabetes, we should look as a comprehensive care that we should give them all the vaccinations. It will prevent them from the complication of this. Herpes zoster is one of them, pneumococcal, and so on, influenza vaccine. So all of these vaccinations we should discuss with the patient in each visit. If this patient, he don't take it, he should take it. Now we'll go to section 6. We're talking about ADA-AST in 2026, the draft consensus. They tried to talk about management of hyperglycemia in type 2 diabetes management. So in ADA-AST, they said earlier GLP-1 SGLT2 inhibitors should be started from the time of the diagnosis as early as possible. They said also look for the complication like CKD and cardiovascular disease. Try to look for fatty liver, muscle MASH, cognitive osteoarthritis. All of these we can give GLP-1 agonist SGLT2 inhibitors. They will benefit from these medications. Frenolone is one of the medications that it not only for chronic kidney disease, also they having cardiorenal protections. It will decrease the micro and macroalbuminuria. Oral GLP-1 agonist classes is one of the classes is coming in and giving us solutions in diabetes and obesity patients. Also, injectable medication is available for those patients, diabetes and obesity patients. Lifestyle and self-management, we don't forget to tell the patient that physical activity is very important. The patient should having physical activity 150 minutes a week from moderate to high activity strength, 2 to 3 times per week, light exercise, resistant every 30 minutes while sitting, and they should have 500 steps daily. Home and economic circumstances should be very important. Patient-centric communication principles is very important. So social is very important for those patients. Nutrition, the patient should having good protein intake, more than 0.8 to maintain their lean body mass and to be more strong. Sleep, the patient should sleep from 6 to 9 hours per night. This is very important. Self-management educations, so personal full involvement in monitoring, planning, sharing decisions, side effect tolerabilities. Also, person-first approach that language matter, remove from stigma terminology, try to not appease patients. They said patient with obesity or with overweight, start to remove this stigma from the patient. So person is first rather than the language. So we try to move from the stigma for the patient and we make them this problem. Now we will talk about last section for today, that new generation obesity therapy. So we have multiple obesity pipeline summary. This is summarized, and we have a lot of medication. They will come in the next few years. For example, retatrutide, GIP, GLP, glucagon, triple therapy. So this is expected to have weight reduction about 28%, which is highest ever pharmacological weight management treatment. They have very effective in obstructive sleep apnea and osteoarthritis benefit. And also we have eniceptide, which is GLP-1 GIP double agonist. It decreased about 22%, which is achieved also 30% in weight loss in some patients. Cagrisema, which is semaglutide with cagrilintide, is a combination therapy. Also one of the strongest medication to decrease glycemia and weight management. It decreasing weight about 14%. Also survodutide, GLP-1 agonist glucagon double agent. It have decreased 16% in the weight, but they have 34% decrease in visceral fat and 60% in liver fat. So with lean mass preserved, which is one of the well-known medication, they will come soon. It will be very effective in those patients with fatty liver. Also, we have zenagamtide, which is GLP-1 with amylin double agent. They will decrease weight about 14% and good tolerability profile. Also, we have petrelintide, which is amylin analog. So they have 10% decrease in weight, but they have minimal GI side effects. So no vomiting at top doses. Or for glupron, as we said before, is one of the well-known medication. The good for this medication can be taken with water or without water, with food or without food, and have been a good decrease in their weight as an oral medication, non-injectable. So as you know, some patients, they will refuse any injectable medication and they prefer oral medication, and their number is not, they are good number of patients, they will refuse injectable, and this is ortho is one of the solution for those patients. So now what's the take-home message? Take-home message that patient-centric approach is very important. We should look for the comorbidities. We should look for all aspects of the patients. So in type 2 diabetes and those patients with atherosclerosis, cardiovascular diseases, GLP-1 agonist with proven cardiovascular benefits is the first choice, plus SGLT2 inhibitors. Type 2 diabetes with heart failure, any heart failure, either preserve ejection fraction or reduce ejection fraction, half PIF, half REF, SGLT2 inhibitors is the first, plus GLP-1 agonist if obesity or half PIF is available. Type 2 diabetes and CKD, SGLT2 inhibitors should be considered, plus Frenolone, especially if albumin-creatine ratio more than 100 and GFR from 30 to 90. Type 2 diabetes plus obesity, BMI more than 30, GIP, GLP is very important medication, or GLP-1 agonist plus SGLT2 inhibitors. Type 2 diabetes with MASH or muscle, so GLP-1 agonist or GIP, GLP is medication of choice, like semaglutide and tirzepatide. Type 2 diabetes only without comorbidities, metformin, MR plus SGLT2 inhibitors is a first-line therapy, as NICE guidelines said. So practical clinical peers, so they try to have screening and strategy for cardiovascular risk. Look for comorbidities, try to choose for your patient the best thing. Don't use GLP-1 with a DDP4 inhibitor together. One of them is enough. Over CGMs for those patients, especially for those patients having hypoglycemia. Insulin user, for sure, you should use for them, but non-insulin users start to use it for some of them if they having benefit. 6-day rules is very important to stop some medication like metformin, SGLT2 inhibitors. Then after that, you resume it after that. Start SGLT2 inhibitors as earlier as you can. Counseling the woman in GLP-1 agonist in each visit, especially in those patients in semaglutide or Ozempic, they should stop 2 months before, tirzepatide 1 month before. Address the adherence. Very important that to check for the patient if they are adherent to their medication, and try to think always beyond weight. So try to think about address all the complication like fatty liver, like all comorbidities related to the obesity and to the diabetes. This is my reference for the talk today. If you have any question, please write in the chat box so we can answer your question.
Thank you so much, Dr. Raed, for informing us about all of these updates that have taken place in the very first 7 months in 2026. We received multiple questions and we are waiting for more if you have any. So I'm reminding our attendees to drop their questions in the Q&A section. The first question to ask about is from Dr. Ahmed Al-Haj. Dr. Ahmed is asking if you can give a comment on the weekly insulin, the EcoDec.
Yeah, this medication is one of the excellent medication. It's approved for type 2 diabetes patients. It's giving once weekly. Having the same reduction for hemoglobin A1C and same reduction and same risk for hypoglycemia. So rather than to give the patient injectable medication 365 days a year, it will be 52 injectable a year, which is very easy for the patient. The most important question that how we calculate the dose, especially for those patients already on this medication, usually we calculate the dose very easily. That we calculate the dose. For example, if the patient already in 10, we multiply the dose on 7. So the patient, for example, they will have 70 units once time a week.
Okay. Another question from Dr. Salwa is asking about the use of statins in old age diabetic patients.
Yeah, this is a very important question. We should use the statin for elderly more than 65 diabetic patients. So especially if their LDL more than 2.5 or 100 milligram per deciliters. This is in regular diabetic patients. So all diabetic patients, we consider those patients as very high risk. So high risk is more than, we should make them this less than 100. Those patients having already cardiovascular diseases, we consider them very high risk. So we should increase it to less than 70. So we should make it more, less and less. For those patients, very high risk, so they will have multiple comorbidities, multiple cardiovascular diseases, we should make their LDL less than 55.
Okay. Another question about statins as well. If we have given statins to diabetic patients, at which time could it be stopped? Or
So, yeah.
The stopping of the statins in
Yeah,
diabetic
this is very important, I think, question, and always it's a mistake from the physician that when they give a statin, they give a statin for diabetic patient, then after that, if improved, they stop, then the LDL coming up, then they stop and resume again, and so on. So in any diabetic patient, they are not controlled. They are when they give him a statin, they are controlling in the statin. So don't stop the statin. If the patient reaching the normal range, continue in the same dose of statin as much as you can.
Okay. Another question, I think it was sent at the slides of the guidelines. The question is it GLP agonist before insulin therapy?
SGLT2 inhibitors before insulin therapy? GLP, okay.
Yeah.
So GLP-1 agonist can be before insulin and can be after insulin. But in the guidelines, they said to use the GLP-1 agonist as early as you can, especially for those patients atherosclerosis cardiovascular disease or at risk of atherosclerosis cardiovascular disease, or those patients, there is some GLP-1 agonist approved for CKD patients, and they have improvement in that. Those patients having obesity or patient having HFpEF, they are approved, they are indicated to use SGLT2 inhibitors, and they are good to be used, this medication with them. So yes, GLP-1 agonist better to be used before insulin. But if you are already in insulin and patient come to you and he's atherosclerosis cardiovascular disease, type 2 diabetes patient, obese, patient having HFpEF or cardiovascular diseases or chronic kidney disease, so you should discuss with the patient about GLP-1 agonist, especially if having increasing weight and obesity, and we talk to him about all the benefit from this medication.
Which is why SGLT2 inhibitors and GLP-1 receptor agonists are recommended for many patients even if their blood sugar is controlled.
Usually, SGLT2 inhibitors and GLP-1 agonist is drug of choice, as we said before, as early as we can to protect the kidney, to protect the heart from the complication. Also, it having additional benefit in weight management. SGLT2 inhibitors, it will decrease the weight. GLP-1 agonist, it will decrease the weight. Also, another benefit from SGLT2 inhibitors and GLP-1 agonist, also it's kind of medication that it will not increase risk of hypoglycemia, which is one of the goal that we should control diabetes without hypoglycemia, without any other risk factors, and to prevent complication. So that's why we said SGLT2 inhibitors and GLP-1 agonists is one of the medication that we should make them priority for our patients in addition to plus minus metformins. But those medication having additional benefit in many aspects, like fatty, now they add fatty liver, kidney disease, so kidney, liver, heart. So they have a lot of benefits for those class of medications.
This is the last question. Is asking about how do stress, sleep deprivation, mental health affect blood glucose control, and how should healthcare professionals address these factors?
Thank you so much. There is paper just published a couple of days ago they found that there is very clear correlation between the sleep hour and blood sugar control. Those patients, they don't sleep well. Usually their blood sugar is high. Also, those people, they don't sleep well. They are prone to be more obese. They to be more sweet eater. They be more stress, more their cortisol level, it will be higher. So please take 7 to 9 hours at least 7 hours they said from 6 to 9, but at least 7 hours a day, good sleep to prevent all the complications, to have good rest for your body.
Okay, I think we have answered all the questions. Thank you so much, Dr. Raed and Dr. Ashraf, for your presentations today and for updating all of us. Now I leave the floor for my colleague, Dr. Ahmed Yunus, for the competition announced in the beginning of this CME. It will not take more than 5 minutes. So I hope all of you can share in this competition. Thank you.
Thank you, my colleague Christine. I would ask about the voice now clear and the screen. Okay. First of all, I would thank thank you, Dr. Ashraf Amir, Dr. Raed, for the fruitful sessions, and thank you all for your attending today. And it's time for competition, but before we go for it, I would like to briefly introduce our company, Eva Pharma, for all of you. We are one of the leading international companies in the region, empowering the fight for health and well-being as a human right. This is our main objective. This is our vision. We are believing that every person has the pure rights to have a very good and excellent health care anywhere. Now we are operating in more than 40 countries, and we are partnering. We have different business model in different countries, and now we have almost around 5 manufacturing sites in the region, and we are expecting our manufacturing facility state of art here in Saudi to start our manufacturing operation within 2 months. This is started 2 years ago with a partnership with Modern, with authorities here in Saudi, and opening our headquarters office by the end of 2023. And now I would like to show you where we start, where we reach, and our manufacturing site in Sudair. This is the evolution of the manufacturing site, and we are expecting to start this operation by next November, inshallah. This is almost around 5 factories in one complex. We are trying to bring all needed and innovative products for the Saudi market, even the hard and challenging types of it. One of the innovative brands we will bring to the Saudi market very soon, just in 1 month, the first triple combination for diabetes in Saudi. The first combination in Balina, metformin, and XOR fixed dose combination form to simplify the diabetic patient journey. This is the first triple combination or composition empagliflozin, either 10 milligram or 25 milligram. Linagliptin 5 milligram are the same in the 2 packs. Metformin 1000 milligram, XOR 4 are fixed in the 2 packs. The difference here is the empagliflozin concentration, either 10 milligram or 25 milligram. This will improve adherence, will simplify daily regimen for diabetic patient, and will at the end will help to get a better glucose control. As our professors said, empagliflozin will improve cardiorenal protection, and the XR formulation will reduce the GIT side effect from comparing to the IR or normal release metformin. Now let's go for the competition. Please everyone scan the QR code, or you can go directly to www.menti.com and enter the code on the screen. We are waiting, everyone. Then 44. Once we exceed 100, we will start. Please scan the code and just wait to start questions. Okay, let's start. Please add your phone number to contact you if you are one of the top 3 winners. I prefer to put your WhatsApp number for easier communication. Okay. The first question regarding the new oral fixed dose combination for diabetes, which from there are correct? It's a triple combination AMPA, linagliptin, metformin. It's XR form, all answers. The new fixed dose combination. It's triple, AMPA, lina, metformin, XR4, or all answers. Okay, for sure, all answers. The next question. Which component of the new triple fixed dose combination has cardiorenal protection? Is it empagliflozin or linagliptin or metformin? Which component contribute to cardiorenal protection? Empagliflozin, linagliptin, or metformin? For sure, it's empagliflozin. Now, the common questions. Metformin XR form demonstrates superior GIT tolerability compared to the IR form. The XR form is more tolerable than the IR form. True or false? For sure, yes, true. We have only another 2 questions. But before we go for the list of questions, we would like to say the ranking till now. Juicy, Omar, and Iman are the top 3 till now. We still have 2 questions we can have compete on it. Let's start. The new fixed dose combination for diabetes has 2 concentration. Okay, linagliptin and metformin are fixed. Linagliptin 5 mg and metformin 1000 mg XR, while empagliflozin is different, either 10 mg or 25 mg. True or false? Is the difference only for EMBA or another thing? Yes, for sure, true. Yes, linagliptin and metformin are fixed. 5 mg linagliptin and 1000 mg XR are fixed, while empagliflozin is different, either 10 mg or 25 mg. The final question. The new triple fixed dose combination daily dosing. What's the daily dosing for the new triple fixed dose combination? By the way, it's named triglyceric. Triglyceric, either once daily or twice daily. Yes, for sure, it's once daily. The triglyceric or the new triple fixed dose combination XR form daily dose is once daily. Now let's announce the 3 winners with us. Juicy Pelias, the first ranking, and Muhammad Hesh second, and Iman Ahmed are the third. Okay, thank you everyone, and dear Christine, the floor is yours.
Thank you so much. I would like to finally thank my speakers, our speakers, my colleagues, and all the attendees who stayed with us till now. Thank you so much, and stay tuned for our upcoming waves of CMEs. We will now end this meeting. So thank you so much, and have a good day. Thank you.